Khorsandi. I just want to say thank you to the Lynetta Walgren Fund, along with Janis Black-Warner. These two consistent sources of funds help support all the work that we do. So we're so grateful to you, Janis, and the Lynetta Walgren Fund. So I turn the meeting over to Pargol Khorsandi, who is, you can begin speaking, and if you want to share the screen, however you liked.
So thank you, Sharon, for that introduction, those kind words, and for inviting me to come back to speak for NAMI West LA. So as Sharon mentioned, I'm currently the pharmacist in charge for the inpatient side of the UCLA Resnick Neuropsychiatric Hospital. So I work closely with the physicians and staff over there, overseeing the medication side of the treatment for the patients hospitalized in all three of the units there. So today I'm going to be really talking about medications that have been approved for mental health indications in the last probably 4 or 5 years, just kind of talking about what makes them different or the same, or you know, what all the buzz is about with these new medications. And then hopefully we'll have some time towards the end to field some questions that you may have. So I'm going to share my screen because I have some slides and it's easier for me to see. Okay, is that working? Can you guys?
Yes, I can see it.
Great. Okay. So we'll talk about these 1, 2, 3, 4, 5, 6 or 7 medications that have been approved in probably the last 5 or so years. And then I always like to end on a note of hope. So I like to talk about things that are, you know, on the horizon and almost close to being approved, and talk about what we know so far about those. So I really like this. I just want to start with this slide because from the last, looking at all the new medications that have been approved since 1985 that have new mechanisms of action, we see that there really wasn't much happening for a while, but in the last couple of years, we've had some really new breakthroughs with medications and how they work and working differently. So it's really an exciting time to be in mental health. I think there's a lot of things that are happening that are very exciting. So let's jump right in. So I'm kind of going to go in a reverse chronological order. So I'm going to start with most recently approved medication, which is Caplyta or lumateperone. So this medication was approved about a year ago. It's currently indicated for the treatment of schizophrenia in adults, and it's being studied for other indications such as bipolar depression, behavioral disturbances in dementia, including Alzheimer's dementia, sleep maintenance insomnia, and other indications. And there is some investigation going on about formulating this medication into a long-acting injectable, which is really exciting. So this medication has only one dose. It's only available in 42 milligrams. It is the starting dose and the ending dose. So in that sense, it's really an easy medication. There's no titration required for it. The starting dose is the effective dose. It does cause some somnolence, so it is recommended that it's taken at bedtime, and it needs to be taken by food, with food, excuse me. The other thing about this medication is that it's metabolized by the cytochrome P450 system. And this system, I only mention it to say that these medications tend to have quite a bit of drug-drug interactions. So something you want to be mindful of if this is ever a medication that is taken. And because this medication just recently came out, they have one long-term study, which I'll talk about, where the medication was studied for about a year. But outside of that, we really don't know, long-term effects of the medication because it is so new. So that's really something that's always, there's a wait and see period to see how well this medication really does play out. So in terms of how it works, this medication binds. So if anybody's read the news releases about this medication, they are saying that it's a novel mechanism of action. It's considered to be novel because not only does it affect serotonin receptors and dopamine blockade, but it also affects this D1 receptor. And they say that downstream of that, it affects the neurotransmitter glutamate, which has a lot of buzz surrounding its role in schizophrenia. So they're saying that it's considered a novel mechanism of action because it does work on both serotonin, dopamine, and the glutaminergic system. However, I'm kind of on the fence with whether or not this is actually going to be considered novel, because at its core, really, it works to block serotonin and block D2 receptors, which is exactly how all of our other antipsychotics, second generation newer antipsychotics work. So the novel part is this D1 blockade that can lead to affecting the glutaminergic system. And while we think that that has some benefits, and there's a lot of clinical trials looking at this system, there's really hasn't been anything to prove that this in and of its own can help with schizophrenia. So it's kind of really a big question mark that's out there. The other thing that sets this medication apart is the ratio of how much it blocks serotonin compared to dopamine. So these are binding affinities, and the smaller the number is, the better it binds to the receptor, the stronger it binds, and the more active it is. So here we see that it's much more affinity to blocking the serotonin receptors versus dopamine. It's about a 1:60 ratio, which is quite high, higher than most of our other antipsychotics. The other novel thing about this antipsychotic is that it blocks the serotonin reuptake inhibitor. And this is how our SSRIs basically work. So things like Prozac and Lexapro also block the serotonin receptor. So it kind of has that built into it. The difference is that when this medication binds, we get about 30% blockage. With our serotonin reuptake inhibitor antidepressants like Lexapro, it's much higher percentages. We're seeing blockage happening at 80%. So it's kind of like a mini antidepressant built into the medication, which could be beneficial because a lot of times we see our patients with schizophrenia requiring antidepressants to kind of help with some of those negative symptoms as well. Okay. So in terms of the efficacy, it's been studied in 2 short-term trials that you can see here. Basically, both of these trials found that the 42 milligram dose was better than placebo, statistically significant. Interestingly enough, in this study here, the lumateperone 84 milligrams was not better than placebo. So increasing the dose from this trial was not beneficial. And on the second trial here, the lower dose of 28 milligrams was not beneficial either, not significant in reducing the symptoms of schizophrenia. And so what we see is the sweet spot at 42 milligrams, which is why that's the starting dose and that's the ending dose. One thing I'll note here is that this study here had risperidone. It's really, really tempting to look at this and say, well, this medication works as well as risperidone at this 42 milligram dose. However, the way the study was designed was not an active comparator. They weren't looking to compare lumateperone to risperidone. They just had risperidone there as kind of an active comparator to make sure that their study was set up correctly, because if the risperidone didn't show any improvements over placebo, then they knew something was wrong. So while it's tempting to look at this data and say that it works just as well as risperidone, it's really not a fair statement because that study was not designed to look at that outcome. Another thing that they looked at, this was a secondary outcome, the pro-social factor. So it wasn't something that they looked at as part of their primary. So the study wasn't looking specifically for this, but it was kind of like a secondary thing that they looked at, which is this pro-social factor. And the pro-social factor, it takes a few elements from the PANSS scale, which is what they use in the clinical trials. And it's looking at measuring social functioning, including hallucinatory behavior, suspiciousness, emotional withdrawal, passive social withdrawal, stereotype thinking, and social avoidance. So all of those kind of negative social aspects of schizophrenia that may be troublesome for a patient. And what they found was that lumateperone was beneficial in that aspect, in that pro-social factor. Again, the trial was not designed to look at this specifically, so they can't really say that it's beneficial for this. However, it does show that there could be some potential for it. And in terms of side effects, I think this is one of the areas where lumateperone has a big advantage. It's the tolerability in the trials was fairly well tolerated. So the most commonly reported side effects compared to placebo were somnolence and sedation and dry mouth. And when they looked at the side effects in the short 4 to 6 week trials, they saw that the patients on lumateperone experienced their rates of metabolic syndrome, extrapyramidal side effects, increases in prolactin, and weight changes were similar to placebo. So in that regard, it's very exciting in that it doesn't have too much metabolic or movement disorder risk associated with it. And it also didn't have any significant impact on the QT interval, which is a cardiac marker. So safe in terms of that front as well. And it has one black box warning for the increased mortality in elderly patients with dementia-related psychosis. This is a black box warning that any antipsychotic gets. Every antipsychotic on the market right now has this black box warning. So it's not really anything above and beyond what we're seeing right now. Again, looking at side effects, somnolence, sedation is high, some nausea inside and dry mouth, but overall pretty well tolerated. So as I mentioned, so this is looking at the pooled data from the acute trial. So this is early data, so 4 to 6 weeks, basically just reinforcing the fact that in terms of fasting glucose, cholesterol, weight gain, and prolactin levels, that lumateperone is pretty on par with placebo. So lumateperone is the blue, and then here we see risperidone, and this is placebo. And then looking at the incidence of extrapyramidal side effects, we see again lumateperone pretty close to placebo in terms of all extrapyramidal side effects, so all the movement disorders, as well as akathisia. They also conducted one long-term study, safety study. So this was basically patients who were in the outpatient setting, who were stable, switched to lumateperone and monitored for 300 days, so for about a year. And what they noticed that compared to baseline for the patient, compared to day 300, these are the changes in the metabolic and weight. And so even in the course of about a year, we don't see any significant increases in these parameters, which is very, in and of itself, is kind of novel because a lot of our antipsychotics unfortunately do cause significant amounts of weight gain and increases in blood glucose leading to a diagnosis of diabetes. Okay. So the next I want to talk about is Spervato. It was approved in October of last year. So this is basically a acenapine, which goes by the brand name of Sapphirus, redesigned to a patch formulation. It is indicated for adults with schizophrenia. It is the only patch, is the only antipsychotic available in a patch. So in that regard, it is very exciting because it does provide a different route of administration that we've never seen before. The patch is applied daily, so you do have to take off the patch every day and replace it with another patch. So only one patch should be worn at a time, and they recommend rotating between these 4 sites so that the skin doesn't become too irritable. So when we talk about the patch compared to the oral acenapine, well, as I mentioned, it's the only one available. It's the only antipsychotic available transdermally, which is exciting. And compared to the oral acenapine sublingual tablets, this is only once a day, whereas those are dosed twice a day. These sublingual tablets have these food restrictions where you can't eat or drink. I believe it's 10 minutes before and after. So it requires, somebody who can comply with those. It also, because it's going through the skin and not being ingested orally, you have this potential to reduce some of the GI side effects associated with it. And the acenapine sublingual tablets, a lot of patients have reported that it has this bitter, unpleasant taste, and it can cause some numbing of the mouth. And as you would imagine, if we completely bypass oral administration and give it via transdermal patch, then we would bypass those side effects as well. However, the transdermal patch, because the active molecule is still asenapine, there's no effects on extrapyramidal side effects, especially akathisia and weight gain that we see with asenapine. So taking the patch versus the pill wouldn't make any difference in that area. There is some application site reactions. Some patients have noted some skin reactions. It is still contraindicated in patients who have severe hepatic impairment. And then there's this cost issue. So I believe oral asenapine, the sublingual asenapine tablets are going to go generic very soon. And so that should bring down the cost. However, this transdermal is considered a new entity, and so it's going to be very expensive. It doesn't surprise me that this transdermal has gotten approved right when the oral is losing its patent. And so I think they're just trying to kind of recover some of the profits there. So there are some benefits to it if someone, has difficulty with asenapine, with these issues here, it could be beneficial. However, again, it doesn't really affect the side effects, which are some of the bigger ones like akathisia and weight gain. Okay, so the next one is Zulresso brexanolone, approved in March of last year. This medication is a controlled substance, so it's a C4. Kind of like our other benzodiazepines that are on the market. And this is the only medication approved for postpartum depression in adults. And the way it works is different than any other antidepressant on the market. And I'll go over that. Because of the way it works and some of the side effects, it's only available through a restrictive REMS program. And I think the biggest hurdle for this medication and why it hasn't really been I haven't seen it be used very widespread, even though it's very new in the way that it works, is because it's required to be administered through a continuous infusion over 60 hours. So over 60 hours, the patient is going to be have an IV line in and have this medication infused in them. And then because of the side effects with this medication, it requires continuous monitoring by a healthcare provider. So really, it's not something you can do at home by yourself and just someone comes and hooks you up and comes back in 60 hours to take it out. It requires a lot of monitoring. And so I think it's been really hard to get off the ground because of this 60-hour infusion. So it's really hard to do infusions in psychiatric hospitals. And it's hard to, and not always the medical side wants to treat psychiatric indications. And so there's kind of this limbo of where would the patient go to receive this. So it's kind of, I think, made it a little bit difficult for this medication to be administered. So in terms of the dosing of the medication, it is infused, as I mentioned, over 60 hours. However, there's a titration. So we're going to titrate up to this rate of 90 micrograms per kilogram per hour, and then it gets tapered off. So you go up and you go down. So again, it's not something that's kind of just one and done. It requires monitoring and titration and a healthcare provider. So in terms of its mechanism of action, it affects the GABA receptor right here. It's an allosteric modulator of GABA. And basically that's exactly how our benzodiazepines work. They will bind to the GABA receptor as well, but in a different area than with brexanolone. So given that information, it's no surprise that the medication is considered a controlled substance. Chemically, it is identical. It's identical to endogenous allopregnanolone, which is basically a steroid, a hormone. And what we think happens in postpartum depression is after the mom gives birth, we see a huge drop in these progesterone levels, which can lead to postpartum depression. So with this medication, with the taper and titration, as opposed to seeing the drop dramatically, we're kind of tapering up and then titrating it down. So we get kind of a smooth coming down of the progesterone as opposed to a rapid drop to help with those symptoms of postpartum depression. I think the exciting thing about this medication, besides the fact that it's a brand new mechanism of action like no other antidepressant on the market, and that it's the only medication FDA approved for postpartum depression, is how fast this medication works. So we see improvements above placebo by the end of the infusion. So by the end of the 60 hours, patients are reporting improvements. And that's, a big change from our run-of-the-mill antidepressants that are on the market, which can take, as you might know, 4 to 6 weeks to even start to work. So in terms of how fast it works, it's very exciting new medication to have. So I talked about the limitation being some of the side effects as well. So this medication has 5 black box warnings, 2 of them related to excessive sedation and potential loss of consciousness associated with this medication because it works on the GABA receptor. So if you think about it, our benzodiazepines can also be very sedating. So again, there's no surprise here. It can also cause some hypoxia. So patients need to be continuously monitored on a pulse ox machine. Another black box warning related to this excessive sedation is that any parent or any mother who has this medication is being infused has to have their interactions with their child or children accompanied by somebody else, again, because they may all of a sudden just have loss of consciousness or be too sedated to be able to provide full care. So not only do you need this long infusion, you need to be monitored continuously, there needs to be a healthcare provider there, then there needs to be somebody else there also to help take care of the child. So there's a lot of hurdles here. It's also only available through this Zolresso REMS program, as I mentioned. And then because it has this FDA approved indication for depression, it is going to have this suicidal thoughts and behaviors.
Pargol, excuse me for interrupting, but I don't think this is a medication that is for this audience.
Okay. So
I think just the meds that deal with psychosis and schizophrenia, bipolar disorder, anxiety. I don't think, they're going to have this issue with their adult relatives with mental illness.
Okay. Okay, no problem. I can skip it. Just one addition is that they might be pursuing this for other indications for major depression, this medication. So I just wanted to throw that out there. So I'll jump to Spervato, which is S-ketamine. This was also approved in March of last year. It's also a controlled substance C3, meaning that it's has more of a risk for abuse and dependence. This medication has 2 indications: treatment-resistant depression, as well as depressive symptoms in adults with major depressive disorder with acute suicidal ideation or behavior. Because of the high risks of addiction, this medication also has a REMS associated with it. So the medication needs to be administered in a healthcare setting. The setting, the pharmacy, and the patient need to be registered. The patient needs to be monitored for at least 2 hours after each administration, and it needs to be administered under the direct supervision of a healthcare provider. So this is not something that would be dispensed that you take home and you administer. Each administration needs to be require the patient to come into the doctor's office for administration. And then each one of those sessions will require somebody to drive the patient home. So it's not someone that can go on their own to the appointments. So in terms of how this medication works, this mechanism of action, it's a non-competitive N-methyl D-aspartate or NMDA receptor antagonist. So there's a lot of ketamine clinics around. So S-ketamine, as the name would imply, is very similar to ketamine. It's just one part of a racemic mixture. And so it's believed that by blocking the NMDA receptors, you have downstream effects on GABA receptors, as well as affecting glutamate receptors. So this again is a completely novel mechanism of action. There's no other medication FDA approved for depression that has this mechanism of action. So in terms of the efficacy slides, I just want to point out that when they studied this medication, they looked at it in treatment-resistant patients for treatment-resistant depression. So patients had failed at least 2 other antidepressants and were moderately to severely depressed. And when they started the Spervato, which is a intranasal administration, they also started a new antidepressant. So when this medication is started, it's only been studied in conjunction with another oral antidepressant. So here, when we look at the studies for treatment-resistant depression, the really exciting thing about this medication is that it shows effects within the first 28 days. So when they looked at these studies, their primary endpoint was at day 28, but even earlier, as soon as even 24 hours or by day 8, we saw separation from placebo. So this medication works really fast, which is very exciting. When we look at the indication, and in terms of long-term efficacy of esketamine, in terms of response, 70% of patients were less likely to relapse, and 51% of patients who were in remission were less likely to relapse after about 80 weeks. So what we're seeing is sustained effects. So it works very early, and it works in the long term as well, which is very exciting.
Yeah, great.
In terms of the indication for major depression with suicidal ideation, these were patients who, with moderate to severe major depression, who had active suicidal ideation with intent. So this is like, the highest risk patient group. And so what they did is they compared these patients, they gave them either the intranasal Spervato or a placebo with standard of care. And here they were looking at the effect after 24 hours. So they were specifically looking after 24 hours. And after 24 hours of receiving that intranasal, we saw separation from placebo, meaning that there was significant improvement in the patient. And that separation was seen starting as early as 4 hours. So this medication really does work rapidly, which is why they gave it this indication, which no other medication really has. So again, it's very exciting because of how fast this medication works, unlike any other medication that we have to treat depression on the market. The dosing here, so for treatment-resistant depression, we start out weeks 1 to 4, it's the induction phase, receiving it twice a week. And then in the maintenance phase, we would receive it weeks 5 to 8 once a week, and then weeks 9 and beyond, either every week or every 2 weeks. So it's requiring you to go to the physician's office or the healthcare provider's office twice a week at the beginning, and then once weekly, and then either weekly or every other week to receive this medication. In terms of the dose for the major depression with suicidal ideation, they gave the max dose of 84 milligrams twice weekly for 4 weeks. Beyond that, it really wasn't studied. So the thought process is potentially you would move on to the maintenance dose of esketamine or potentially an oral antidepressant. But because this is such an acute event, the suicidal ideation, they only really studied it for only 4 weeks, and there's no long-term studies for that. In terms of the administration, I have several slides, but in the interest of time, I'm not going to really be specific, but just to say that it's really an easy intranasal administration. So the patient administers it themselves in the doctor's office. And the important part is because it can cause some nausea, they really recommend not eating for 2 hours before and no liquids 30 minutes prior to the administration in case the patient does have some nausea and vomiting. But basically it just goes one spray in one nostril and then the other part, half of the spray in the other nostril. And then each of the sprays are 28 milligrams. So the patient may require 2 to 3 canisters depending on their dose. And then the canister gets tossed in the doctor's office in their bin. So the exciting thing about the esketamine is how fast it works. The flip side of that is the safety risks associated with it. So it can cause increase in blood pressure and dizziness and some disassociation, sedation, lethargy, and anxiety. The ones bolded here are the main side effects. So it does have some huge side effects, risks associated with them. Most of these side effects, kind of peak within the first hour or two and then kind of dissipate. And so that's why patients are required to be monitored for 2 hours after each session, just to make sure that their blood pressure is okay, that their cognition is okay, they're able to function, and then they're sent home with a loved one as opposed to going home alone. And then esketamine does have a few contraindications, all really related to the risk of increasing blood pressure. So anyone with any kind of history of intracranial hemorrhage or abdominal aorta or any kind of vascular disease that would that a high blood pressure would make worse, it's contraindicated in, as well as anyone who has any kind of sensitivity to either ketamine or esketamine or any of the excipients. Again, this has 5 black box warnings to kind of drive the point home. So sedation and dissociation is one of them. Abuse and misuse is definitely something that can happen. Really high risk in patients who have a history of substance abuse. It does require a REMS. It does have suicidal thoughts and behaviors because it is an antidepressant. And then one of the black box warnings specifically says that it's not approved in pediatric patients. Oftentimes we use medications in our pediatric population, even though they're not FDA approved, but in this case, there's like a strong black box warning stating that it's not approved in pediatric patients. Okay, the next medications I want to talk about are Ingrezza and Austedo. Both of these were approved, I want to say in 2017. These are VMAT inhibitors. So these are medications indicated for treating tardive dyskinesia, one of the side effects associated with our antipsychotics. So here I'm comparing the two. In terms of dosing, Ingrezza is taken once a day, whereas Austedo is twice a day. This needs to be taken, Austedo needs to be taken with food, and Ingrezza can be taken with or without food. And both of them are metabolized by the same system, so the risk of drug-drug interactions is the same. In terms of side effects, Ingrezza has sedation and akathisia, whereas Austedo has nasopharyngitis, sedation, and some akathisia as well. And then in terms of some major risks with Ingrezza, it's QTc prolongation, so some cardiac and as well as Parkinsonism. And then with Austedo, we see the same QTc prolongation risk, the risk of neuroleptic malignant syndrome. And then they found with this medication specifically, even though they work exactly the same, suicidality in patients with Huntington's disease. So in terms of how it works, as the name implies, it inhibits VMAT. And what VMAT does is basically, it takes all of the dopamine and serotonin that is in this neuron, and it packages it into these nice vesicles for it to then be released into the synapse, so then it can go to the receptors and cause the signaling. So VMAT helps package them into these vesicles. And so what these VMAT inhibitors do is that they inhibit those neurotransmitters from being repackaged and released. And so the net effect is that we see a decrease in the amount of dopamine being released into the synapse, thereby helping tardive dyskinesia. Because we believe tardive dyskinesia happens when our receptors become very sensitive to dopamine. So just a little bit of dopamine gives a very exaggerated response. And so by decreasing the amount of dopamine we put into the synapse, then we're hoping that that won't get as much of that exaggerated response. So I've seen patients swear by this medication that the tardive dyskinesia is really improved. So I have seen it be very beneficial. My only thought is the body is very smart. And so I feel like after a while, the receptors are just going to become more and more sensitive because there's less dopamine around. And so I'm curious to see in the long term if the benefits seen with this medication are sustainable. Okay, I'm going to talk for a few minutes about dopamine receptor partial agonists. So the first one that we know well is Abilify, was approved in 2002. And then in 2015, 2 more dopamine receptor partial agonists came on the market. The first is Rexulti or brexpiprazole, and the other one is Vraylar, cariprazine. So both of these medications are dopamine receptor partial agonists. So just a little bit of background on dopamine receptors. If they're too much dopamine, we get psychosis and these psychotic symptoms. And so our medications block block dopamine receptors completely. And so when we don't have enough dopamine, we get the psychosis, which re-emits, but then we get these movement disorders that are associated with it. So these dopamine partial agonists are kind of just in the middle. They're not fully blocking the dopamine receptor, and they're not fully engaging in the dopamine receptor. They're kind of just right in the middle to help alleviate the symptoms of psychosis with, in theory, less extrapyramidal side effect risks. So when we compare Vraylar to Abilify, their effects on the dopamine D2 receptor is the same. However, Vraylar has a higher affinity for the D3 receptor, which is another subset of the dopamine receptors. The clinical advantage is really unknown, but it's proposed that because it does affect the D3 receptors more, that it has more pro-cognitive effects. So helping with the cognitive side of schizophrenia, which is something that really no other antipsychotic really can help with. When we compare Rexulti to aripiprazole, Rexulti has lower intrinsic dopamine activity and has much higher affinity for the serotonin receptors. And so in theory, what that could do is potentially makes it more tolerable. So you're seeing less of those extrapyramidal side effects that are associated with the dopamine receptor, and perhaps some anxiolytic activity associated with it, since it does have such higher affinity for the serotonin receptors. And then in comparing the three, how they compare, at this point, aripiprazole is available in generic, so there is some cost implications. Aripiprazole is also available in different formulations. So it's available not only in a tablet, but as an oral solution, a long-acting injectable, and an oral disintegrating tablet. So we have a lot of options for taking this medication, whereas brexpiprazole and cariprazine are only available as a tablet or a capsule at this time. In terms of drug interactions, they're all about the same. All of them get metabolized within the CYP system. All of them only need to be taken once a day, which is beneficial. And then all three of them have moderate binding to the histamine receptors, so really not too sedating. And then they all have low binding to the muscarinic receptors, so you don't anticipate that they're going to have a lot of anticholinergic side effects associated with them. And then in terms of tolerability, what we see is the number one side effect reported with aripiprazole is akathisia. With brexpiprazole, we see some weight increase and less akathisia. Again, as I mentioned, it has less dopamine blockade and more serotonergic activity, so it does have less of those movement side effects. And then cariprazine, again, extrapyramidal side effects seem to be the main adverse event. Okay, so I'm just going to spend a few minutes talking about promising pipeline. Two new medications that are, pretty in phase 3 and close to getting FDA approval. The first one is by Alkermes. It's Olanzapine, which we all know and love so well. Love and hate, I should say, because it is a fantastic antipsychotic in terms of its efficacy for schizophrenia, but the side effects with regards to weight gain and increases in sugars and cholesterol is very high. So what they've done is they've paired olanzapine with Samidorfan. Samidorfan is an opioid receptor antagonist. And so what this does is, in theory, you get the benefit of the efficacy of olanzapine, and adding the Samidorfan helps to address the weight gain associated with olanzapine. So they've studied this medication in two main studies, the Enlighten study, one which looked at its efficacy. So they looked at it compared to placebo and found that, yes, it does work in terms of an antipsychotic. And then they compared it with olanzapine, not in terms of its efficacy, but in terms of its weight change. And what they did see is that the proportion of subjects who had weight gain was much lower with the combination of olanzapine and Samidorfan compared to olanzapine alone. So they did one study looking at its efficacy compared to placebo, and one study looking at its weight compared to olanzapine. In theory, it is olanzapine, so it should have the same efficacy, but they haven't done those kind of head-to-head studies. So that's an exciting new medication. And in terms of where we stand, they did apply for a new drug application. And last month, they received a complete letter response. And so basically, they didn't identify any concerns about the clinical efficacy or tolerability of it. They had more problems with the manufacturing facility that it's being made. And so I think the thought process here is that once those manufacturing issues get resolved and they show the FDA that they've made those changes, that potentially, or most likely, this medication will get approved soon. The main thing with this, once it does get approved, it is an opioid antagonist, so it blocks the opioid receptor. And so it's really important, if anybody is currently or has recently used an opioid, whether for therapeutic pain reasons or illicit use, that this medication could cause withdrawal symptoms in those patients. And then the second medication is zuranolone. So basically, this is the little sister of brexanolone, which was what I spoke about briefly for postpartum depression. It's an oral version of that IV medication. It has the same mechanism of action, but they've seen positive results for postpartum depression, and they're also studying this for major depressive disorder. So there is some data there to show that it could be beneficial. And then they're also looking at it for treatment-resistant depression, since it does have this new mechanism of action. And again, if it does get approved, it'll likely be a controlled substance because of its effects on the GABA receptor. This is just a busy slide to say there's a lot of studies out there looking at this medication. The results for postpartum depression look really good. The results for a major depression are kind of so-so, and we'll see as they do more studies whether this pans out or not. But if it does, it's very exciting because it's a new medication with a new mechanism of action that can be taken orally instead of infusion. And if it works as fast as its IV counterpart, or even half as fast as its IV counterpart, then it could potentially work fairly fast. Okay, so that's everything I wanted to say about medications that have been approved recently. I know I kind of talked kind of fast and a little technical, but I found that the NAMI West LA group is really knowledgeable, and they really can follow along. So I hope you were able to follow along. And at this point, I'm happy to entertain any questions anybody has about what I spoke about or medications in general, as long as time permits.
I have a question, if I could start out.
Sure.
Thank you for your presentation. It was excellent. It was so easy to follow.
Oh, good.
Very complicated process. Thank you. And I do have a question about lumateperone. Are the doctors at UCLA using that now, or
So
are they?
that's a very, very good question. I work primarily on the hospital side. And so on the hospital side, we tend to see a lag just because the reimbursement for those is a little bit tricky in the hospital versus on the outpatient setting. For example, we can't use samples, and there's a lot of other nuances associated with it. And the medication just came out about a year ago. It was FDA approved. And after it gets FDA approved, there's like a little bit of lag time for it being, coming to market. And full disclosure, I haven't been to work in 6 months. I've been on maternity leave. So I can't say definitively if they're using it or not. But if, if I can go based on what we see happen with medications once they get FDA approved, it usually takes a little while for it to there to be some uptake on the inpatient side. I think on the outpatient side, I could see it being used a little more often. But I can't tell you definitively. I haven't been there in 6 months. So
when you're there,
Mhm.
and in your role in the pharmacy, do you make recommendations to the psychiatrist about cocktails for treating the patients based on the symptoms that you see in their records?
Yes. So I'm not sure if you guys know this. This is for every hospital, not just UCLA or in terms of psych, but every medication order that is written by a physician in a hospital has to be approved by a pharmacist before it gets administered to a patient in any hospital setting. It's like in California, that's the law. So a pharmacist is always reviewing medications before they give. There's very few circumstances like emergency medications where it can be bypassed, but I would say 99% of the medications are. So every medication in the hours that I'm there, so I'm there, 40 hours a week, every medication that goes through, I have to approve. So I'm always looking at the medications, looking at the patient's profile, deciding if it's appropriate, the dose for the patient, and then making recommendations when I see the meds come in. And then also the psychiatrist will come to me and ask me for recommendations. Like, we have this patient, what do you think about this? What should we do? How should we treat this? So I work very closely with the psychiatrist on the hospital side, helping come up with, the best pharmacological treatment for the patients while they're there.
It's very reassuring to know that you're there. Many of us have our loved ones that are followed by your excellent monitoring. Thank you.
Can I ask a quick question?
Sure.
I appreciated the presentation a lot, and it was very relevant to me because my son, he has been diagnosed with bipolar 1 disorder, and primarily, he's been taking lithium for 2 years, and it's really helped handle his mania. But he's experienced a lot of weight gain, and but was able to carry on with his life and go to college this year. And it's not only because of the pandemic, but I think the pandemic exacerbated it. He's experienced for the first time some real depression. And he actually had to come home from college about 6 weeks ago, and his doctor prescribed Vraylar to treat bipolar depression. So he's been taking it for a month, and it seems to be going well, but he's definitely like his mom reports he's really been doing a lot better, but he's so hungry all the time. And is that, I actually missed that part, if that was one of the side effects of the Vraylar. I know lithium, I know he has felt it pretty much with the lithium too, but.
Right, so it is definitely, the lithium can cause it. The Vraylar doesn't have that much weight gain associated with it. It is my belief that any of the newer agents that the FDA approves for schizophrenia, bipolar depression, any new antipsychotic, I would be surprised if they approved something that has significant amount of weight gain associated with it. We have so many great medications already that have weight gain that I don't see the FDA approving it. I think recently they've been very big about not only efficacy of a medication, but safety. And from what I recall, Vraylar doesn't have too much of a weight gain associated with it. However, that's the majority of patients, and majority is not everybody, and everybody is different. So I think in theory, it could potentially cause it, even though it's not very common. So I would say it's possible that it could be from the Vraylar.
But it sounded like you were pretty optimistic about its efficacy.
Yes, its efficacy, yes. I mean, it's another antipsychotic with very similar mechanism of action. So I think that it does have good efficacy. And I know that my psychiatrist, so Vraylar came out 5 years ago. So I'm slowly starting to see it on the inpatient side, people coming in using it. And they seem to really like it and say that it's a fairly good medication. So
thank you for that.
I've heard good things about it.
I see there's some questions in the chat box. Was anybody else have their hand up, or?
So the question in the hand box is,
نه هنوز
what would
حتی
you,
یه 10 دقیقه دیگه تموم میشه.
so would you like me to read the question, Tim, or would you like to read it?
Oh, sure. The first one I see is, what would you try for mania and psychosis in a 72-year-old woman with lifelong bipolar 1 who objects to the side effects of Zyprexa? My son objected as well.
Yeah, I mean, those are not light side effects with Zyprexa, unfortunately. And I'm not even talking about the weight gain. A lot of the patients don't like just how sedated they feel from it. So I have a very love-hate relationship with Zyprexa because it does work so well at treating the symptoms, but the side effects are just so difficult. What would you try for mania and psychosis in somebody with bipolar 1 who objects to side effects? I mean, so I'll be honest with you, it's really hard for me to give clinical advice because not knowing the history of someone, what they've tried in the past, what side effects, what medications, how has it gone, it's really hard to say what can and does not work. I really love lithium for mania and bipolar. It does have a high side effect burden, but I've seen people regain their lives from lithium. So if that hasn't been tried, I would try that. I mean, again, it depends on the side effects of the Zyprexa that they're referring to, because there are quite a bit. So it's really hard for me to answer this question without, more background. Okay. Let me see. How can family members at UCLA inpatient get their loved ones these new meds? So it's not just limited to UCLA. Oh, the question, let me read the question. It says, how can family members at UCLA inpatient get their loved ones these new meds? So this is a very good question. My answer is not limited to UCLA. It's really most hospitals have their own formulary. So I would say that the person would have had to exhaust and have had tried and failed standard treatments before these newer medications would be used on an inpatient setting. On the outpatient setting, it's a whole other story with other requirements, but on the inpatient side, really, they would have had to fail some of the more older standard ones that are on our formulary before they would be open to trying some of the newer ones. Okay, the next question says, can you talk about TMS, transcranial magnetic stimulation for depression, anxiety, etc.? So my background is as a pharmacist is medications. I really don't know much about TMS, but so much to say that we do TMS at UCLA, that it is something that we've seen patients do have response with, but outside of that, I really can't say much more. I mean, I believe it is FDA approved for depression, so it has to have some sort of efficacy, but in terms of, you know, how to get it or the frequency. Okay, the next question is,
TMS has about a 60% chance of being effective. And Dr. Andy Luchter at UCLA is a TMS doc. It's all over the city. There's many TMS clinics in Beverly Hills and Santa Monica in the Valley, all with psychiatrists. So, you know, it's about a 60% chance effectiveness rate.
Thank you, Sharon. See, I learned something myself tonight.
So any other questions? Okay, I'll be right back. Any other questions, anybody?
I do. Janis does. I do.
Okay,
So-
Janis.
First of all, thank you. You are wonderful. Congratulations on your new baby. And even though my son has paranoid schizophrenia, he's been at UCLA about 11 times. He's 26 now. I have to say, the biggest help for my son, he's on clozapine, was the diet, because the first time he was on it, I refused Dr. Sajay or any doctor to put him back on it. He gained 67 pounds. He was tall and thin and he was huge. And now he's been on clozapine, but he's at a place in New Jersey called Earth House where it's a treatment program, but there's no meat, no dairy, no red meat, no dairy, no sugar. They exercise, they rest, they have no
But
the question, what I just wanted to comment, have you thought about, why don't you guys talk about more about diet? Because I found that when they restrict all these things, like why don't pharmacists work with the diet more?
That's a really good question. I think we do a lot of diet education, or we try to do diet education. It's really hard to, I mean, I think for your son, being in a facility where they can help with that is really beneficial, I would say. I think sometimes it's just very hard for patients to be able, for people to be able to do such a strict thing in the willpower. But in terms of pharmacist counseling, I mean, we do talk about it at UCLA. We have a nutritionist who goes and speaks to all of our patients about diet, and especially the patients who are on, you know, clozapine and olanzapine that have so much of the weight gain. But for us, we can do some diet. A lot of what we've been trained to is not nearly as comprehensive as a nutritionist would be. But we do talk about diet. I mean, it is something that we talk about.
Because I have to tell you, to see it with my own eyes and object for 2 years, don't put him back on clozapine. But clozapine for me was for him a Rolls Royce for schizophrenia, the medicine. But I was reading, I just took a bunch of notes, what you said about this new one. How do you pronounce it? Calypta?
Caplyta.
Why would you change if it's working? If something's working, why would you try something new?
Good question. So this study was, the drug company paid for this study. Mm-hmm. So they enrolled patients who were stable, put them on this drug, on this medication, and then followed them for 300 days to show, hey, you can take your stable patients and switch them and they won't relapse, and then they'll have stable, if not lower weight.
And side effects like drooling or whatever they get.
Right. So that switch was something that the drug company paid for in a study to kind of show, to kind of help people. But really, I unless the side effects are so overwhelming and such a huge burden, I would not recommend switching to a newer medication if you have a medication that's working. There's no way to guarantee that that new medication, even though it works very similarly, is going to be working for you.
Thank
And a
you.
lot of times, I'll just say this as well. Sometimes we see patients doing well on one medication, switch to another medication, doesn't work as well, switch back to that initial medication, and it's never works as well as it initially did. So really, if you find something that works, unless the side effects are so overwhelming that you can't treat it, there's nothing that can be done about it, and they're really bothersome, I would say stay your course, even with all the new medications that come out.
Thank
A lot of it is potential to be better, or potential to help with the social, or potential to help with cognition, but a lot of those things haven't been proven yet.
A couple more questions. Here's a question from Sharon. My daughter has been prescribed Abilify injectables, and Rite Aid wants to charge over $900 per month. I don't know if you can answer this question, Pargol, but is there a way to get the price down? Is there any way to help this family?
That's a really good question. The unfortunate thing about the injectables is that it's very expensive. I would recommend, and it all depends on your insurance carrier. So I can't give you specific recommendations. What I can do is direct you to the Abilify website. So go to the website for the injectable. There's 2 different Abilify injectables on the market right now. Both of them are effective. So I would say go to that injectables website, and they have people there that can help you with that. And then the other thing is, it might be that since there's 2 Abilify long-acting injectables, it might be that the one you're prescribed is not the one that's on your insurance's formulary. So it might be as simple as switching, or not simple, but solution might be switching to the other form of the Abilify injectable that your insurance will cover, and it will be much cheaper. So those are the two things I would recommend.
Another question here. My daughter has schizophrenia and has been on Clozapine for many years. It helps her a lot, but she has excessive weight gain. Her psychiatrist has suggested naltrexone to take in a very small dose to possibly help with the binge eating. What is your opinion of naltrexone to help with binge eating?
Very good question. So naltrexone is an opioid antagonist. So basically, it's similar to how Samidorfan works, which is one of the new medications I was talking about, which has helped decrease the weight gain associated with Olanzapine. So I have seen some data to say that naltrexone can work. I don't know extensively. I think it can potentially be beneficial. And as long as your daughter is not taking an opioid antagonist, as long as your daughter is not taking any opioids, whether recreationally or ones that are prescribed for pain, it could be something worth exploring. It's really something you want to talk to them, but the side effects of naltrexone are not significant, so I don't think it hurts. Again, though, from what I've read, and as Janis mentioned, the best support for weight gain associated with these antipsychotics is changes to diet and exercising, better than any medication out there. Everything that I've seen, that's really the way to do it if possible.
Well, thank you. Any other questions tonight? Well, I think that's the last question. Pargol Khorsandi, you have been so informative. It was a great. Here's one last question. This is the last question. Patients who have had to stop lithium because of kidney damage is starting again after a 15-year break at a very low dose a reasonable thing to try, or no?
Okay, again, it's very hard to answer that question without much background. So I guess it would depend on how significant the kidney damage was. Was it a temporary? Is it now a permanent kidney damage? What else has been tried? Has nothing else been working? Lithium was the only thing that ever worked. So there's a lot of pieces to the puzzle. I think it's worth exploring and speaking with your psychiatrist about. I wouldn't say it's completely contraindicated, and just because it caused kidney damage in the past, that you should never, ever, ever again explore that idea. So I think it's worth a conversation with your psychiatrist.
Thank you so much, Pargol. I think the whole audience is so appreciative of what you've talked about tonight. I know I myself took extensive notes because people are always asking me, and I pretty much say what you say. I can't answer that question, but here's something I know, and ask your doctor. So I want to thank you so much and thank all of you for attending. And I just want to read something from NAMI in closing. It's called Letting Go. To let go doesn't mean to stop caring. It means I can't do it for someone else. To let go is not to cut myself off. It's the realization that I can't control another. To let go is not to enable, but to allow learning from natural consequences for my relatives. To let go is to admit powerlessness, which means the outcome is not in my hands. To let go is not to change or blame another. It is, I might be able to do something with myself. To let go is not to judge, but to allow another to be a limited human being just like myself. To let go is not to be in the middle arranging all the outcomes, but to allow others to affect their own outcomes. You know, to let go is not to deny, but to accept. To let go is not to scold or argue, but to search out my own shortcomings and to correct them. To let go is not to adjust everything to my desires, but to take each day as it comes and live in the present. To let go is not to regret the past, but to grow and look and live in the present with an eye to the future. To let go is to fear less and love more. So I just leave you with that. That's from NAMI. Sometimes these words are helpful to hear. And Pargol, I want to thank you so much for your illuminating conversation on new medications. It was very helpful. Thank you.
Thank you for having me, and thank you for everybody who attended. I appreciate it.
Yes. Thank you.
Thank you, thank you.
Thank you.
Thank you. So we'll see you, see our board members that were on tonight and next Wednesday night for our board meeting. But otherwise, we'll see all of you the first Wednesday in January.
And
Thank
maybe
you,
we'll see
everyone.
some of you around the holidays too.
Yeah.
Happy.
maybe.
Be safe, be well, and have a wonderful holiday season. We're grateful for all of you. Thank you
and
for coming this evening.
Thank you, everybody. And I just want to say, I got a lot out of the postpartum medication. I thought it was interesting.
I thought so too, but now we know why it's so interesting to you, Dr. Nazarian.
Yeah, it was very helpful. The whole thing was very helpful.
Well, I think we all should know about this and to have I don't know how a new mom could go for 60 hours and be, it's hard.
Very
Yeah.
hard. That's why it's not really being used much. But if the oral formulation of it comes out, then it could be very exciting.
You are terrific. I've never had anybody explain medication that clearly in my life, and you are terrific. And it's just so refreshing. We welcome you back when things get better. And
We'll have her
congratulations.
back, Janice. We'll definitely have her back. And
Can I
yeah,
ask you, Dr. Nazarian, one last quick question? Why are all the names to these medications so odd and it's so hard to remember?
If you think they're hard to remember, we got to remember all of it.
I mean, is it some conspiracy of the?
I wish there was some rhyme or reason to it. It would have made my studying during pharmacy school so much easier.
But you need a pharmacy degree to understand. I mean, these names. I don't know. Just
I think the generic name is set by the FDA, and then they try to make the brand name as catchy as possible.
Vraylar is catchy.
yeah, Vraylar is catchy. Yes.
They have whole teams that do a lot of market research and try to find the best, catchiest name.
You know, Abilify is pretty good. That has a good feel to it.
I think we should get nail polish names.
Oh, yeah.
I love that, Janice. Yes. So much more uplifting.
It's really funny. That's a great idea. Can
So-
NAMI Westside have a line of pharmaceuticals with
No,
lipstick?
we have to keep NAMI separate from the pharmaceutical industry. We must.
That's right. That's right. Just strike that. It's bad idea.
We must.
Let's stop recording now, shall we?
Yes.
Before I-
So bye, everyone.
All right.
I
well,
would-
it's clearly past my bedtime, so